There's so much confusion. Well, first, I will define the overlap syndrome. The overlap syndrome is the concurrent diagnosis of obstructive sleep apnea and chronic obstructive pulmonary disease. It may also entail obstructive sleep apnea with pulmonary fibrosis, cystic fibrosis, or other chronic lung diseases, but the proper combination is obstructive sleep apnea and chronic obstructive pulmonary disease. The term overlap syndrome was first used in this context by Flenley back in 1985. So it's an old term. Obstructive sleep apnea, on the other hand, consists of the word apnea from the Greek apneia, meaning no breath, defined as more than 90% reduction in flow for at least 10 seconds. An obstructive apnea is no breath with continued effort, central apnea without any attempt to breathe, a mixed apnea, one event with both central and obstructive components. This is scored as part of the obstructive apnea-hypopnea index, or AHI. Hypopnea is defined as a low breath, a 30% reduction in flow compared to baseline, accompanied by 3 or 4% oxygen desaturation or arousal. And the term RERA means a respiratory effort-related arousal. This is an exaggerated attempt at breathing with flow limitation on nasal pressure, accompanied by an EEG arousal with no desaturation or hypoxia. We define that obstructive sleep apnea-hypopnea syndrome as having at least 5 apneas and hypopneas per hour of sleep. This is called the apnea-hypopnea index, or AHI. This includes both obstructive and mixed apneas. And some overlap syndrome data is based on an apnea-hypopnea index of 15 or greater, moderate to severe sleep apnea. Some is based on home sleep apnea studies with what is called either a respiratory disturbance index, RDI, or a respiratory event index, REI, over 10 apneas and hypopneas per hour of study time, and this includes the very large sleep heart health study data. The term complex sleep apnea is the presence of both central and obstructive sleep apnea occurring in the same individual at the same time and the same night. So it's either primary, which occurs de novo right from the beginning without any intervention, or secondary, in which you have a baseline obstructive sleep apnea with treatment-associated central sleep apnea, or TEXA. And lung disease is not part of this complex. So complex sleep apnea has nothing to do with overlap syndrome. COPD, chronic obstructive pulmonary disease, is conventionally thought of as either emphysema, chronic bronchitis, small airway disease, or some combination of these, usually a combination of chronic bronchitis with bits of emphysema. I would like to distinguish the overlap syndrome, which is the topic of our subject of our talk today, from other newer terms that have come about recently, including the asthma COPD overlap syndrome. So some people have also referred to this as an overlap syndrome, but it is the asthma COPD overlap, not the overlap syndrome. There's no universally accepted definition. It is not a single disease or syndrome. It features chronic obstructive pulmonary disease with elements of asthma or vice versa. For example, emphysema with a reversible airway component. The term chronic asthmatic bronchitis was used in the past for this combination, where the endpoint, was the endpoint in the spectrum of asthma, from mild episodic asthma to chronic asthmatic bronchitis. But this is not the overlap syndrome. COPD definitions include the now most popular gold standards, and some of the data that we have on prevalence of COPD in China are based on the current gold standards, okay? Which stands for the Global Strategy for the Diagnosis and Management and Prevention of Chronic Pulmonary Disease. This is considered a treatable disease, but not totally reversible. The American Thoracic Society and European Respiratory Society have added additional data to say that it's primarily caused by cigarette smoking, and it also produces significant systemic consequences. Now, COPD is mostly caused by cigarette smoking. About 90% of cases of COPD are caused by cigarette smoking. And somewhere between 20 and 50% of all smokers will develop clinical COPD eventually, if they live long enough. Other factors are air pollution, occupational exposures to dust and fumes, including kitchens, and infections. Environmental factors and genetic predisposition, like alpha-1 antitrypsin deficiency. In patients with COPD, the forced expiratory volume in 1 second, the FEV1, declines by an average of 45 to 60 milliliters per year, as opposed to about 35 mils per year in non-smokers. But this can be as high as 120 milliliters per year decline in FEV1 in patients with COPD. About 4% of deaths in the USA are attributable to COPD. The prevalence in China depends upon the definition of COPD. Using spirometry to define COPD, the prevalence is about 8.6% overall in China, with larger numbers in certain parts, especially southwestern China. If you use the gold standard for defining COPD, the prevalence in China is 13.6%. The prevalence of the overlap syndrome is unknown in China, but it is known in some other countries. About 11% of patients in France with obstructive sleep apnea actually have also COPD, therefore the overlap syndrome. In one study done in the United States, the Sleep Heart Health Study, defining patients with obstructive sleep apnea, about 22% of those patients had concomitant COPD. So 22% of patients with COPD had obstructive sleep apnea or the overlap syndrome. A similar study in Milan had similar results. About 20% of sleep apnea patients had overlap syndrome. And in a study that was done in this little small state of Rhode Island in the United States, just looking at outpatients in clinics, they calculated a prevalence of about 2% of overlap syndrome in about 10,000 outpatients in the state of Rhode Island. So we can say, I guess, we don't know what the prevalence is in China, but the prevalence of overlap syndrome in patients with COPD is somewhere about 20%. And 20% of patients with sleep apnea have the overlap syndrome. What are the consequences of overlap syndrome? The first and foremost is pulmonary hypertension. People with overlap syndrome develop pulmonary hypertension even with only mild airway obstruction. There's lower wake PO2 and a lower sleep oxygen saturation. There's more sleep disruption, a higher arousal index, a lower sleep efficiency, increased hospitalizations, more cardiovascular events, both fatal and non-fatal, and an increased risk of death. I'm going to show you why these things happen. The differential diagnosis, most importantly, would be obesity hypoventilation syndrome. Here you have to have a BMI over 30 kilograms per square meter, but usually it's 35 or 40 or greater. You may have abnormal PFTs in obesity hypoventilation syndrome, including some obstructive component and low diffusing capacity, but you don't meet COPD criteria. And there's hypercapnia out of proportion to the PFTs because of the reduced hypercapnic respiratory drive, and a smoking history usually less than with COPD. The treatment of overlap syndrome is, first and foremost, continuous positive airway pressure, or CPAP. This will increase survival and decrease hospitalizations. Oxygen will increase survival in those that are hypoxic with a saturation of oxygen less than 88%, and it will prevent pulmonary hypertension in these patients. The combination of CPAP and oxygen increases survival much greater than oxygen alone. How important is CPAP for the overlap syndrome? So this study done by Stankina in 2013 was a post hoc analysis of data based on over 10,000 patients for over a 3-year period. All had full in-lab polysomnograms with CPAP titrations. All of these patients were treated with CPAP, continuous positive airway pressure. None of them had bilevel positive airway pressure or auto-titrating positive airway pressure. The COPD was based on pulmonary functions with GOLD guidelines. There were CPAP data downloads to monitor adherence to treatment. And a supplemental oxygen was given for those that were hypoxic despite the use of the CPAP. And in this study, this is comparing the deaths that occurred over this 3-year period in those patients with overlap syndrome that either used CPAP, and here, those that were still alive averaged CPAP use of 6 hours, and those that died averaged CPAP less than 4 hours. So if you used the CPAP, you lived. If you didn't use the CPAP, you died. Looking at everything with a univariate model, we can see that the important factors are CPAP and age, and down at the bottom is Charlson index. This is an index of severity of disease. But if you do a multivariate Cox proportional hazards model and take into account all of the varying risk factors, the only two factors that are important are the use of CPAP, hours per night, and age. So the severity of disease had no significance. So once again, what determined mortality, other than age, was simply how many hours of night you used the CPAP. This is clear in this study. In this graph, we can see time to death. The dark black area are patients that used the CPAP less than 2 hours. The next dark one up here is 2 to 4 hours. And then the very light ones that you can hardly see, and because there's no death, are the people that used it 6 to 8 hours. So if you use the CPAP, you didn't die. If you did not use the CPAP, survival was pretty bad. This compares to survival indices in obesity hypoventilation syndrome, which is the other sleep disorder that is associated with an increase in pulmonary hypertension. And you can see if you treat in this case the obesity hypoventilation syndrome was treated by non-invasive positive pressure ventilation or bi-level positive airway pressure, and it made the difference between death and survival. And here in this other study by Moclazy back a while ago, again showing the difference in survival in untreated versus treated patients with OHS. So why is overlap syndrome so bad? Well, let me count the ways. But first, let's look at some physiology and then some pathophysiology. So respiratory function in non-REM sleep has mainly a metabolic control of breathing, with a lower hypoxic ventilatory drive in men, a lower hypercapnic ventilatory drive in men, periodic breathing at sleep-wake transition, an arousal threshold of about 88%, and an increased pulmonary pressure that's negligible of 4 to 5 millimeters of mercury. The minute ventilation is lowered by between 1/2 and 1.5 liters per minute, or about 15%. This is brought about by a decrease in the tidal volume in adults and by a decrease in respiratory rate in children. The PCO2 is increased by 3 to 7 torr. The PO2 is decreased by 3.5 to 9 or 10 torr. The minute ventilation, the oxygen consumption and CO2 production are both decreased by 10 to 20% in tandem. The net effect is a decrease in oxygen saturation by only about 2%, so it's negligible. Respiratory function in REM sleep, on the other hand, changes completely. The arousal threshold goes down to 70%. This is equivalent to an arterial PO2 of about 40 millimeters of mercury. A hypercapnic ventilatory drive is reduced by 67 to 86%. Minute ventilation is lowered like in non-REM sleep, but alveolar ventilation is reduced by 10 to 25% in phasic rapid eye movement sleep. There's asynchronous breathing, and there are central apneas lasting from 10 to 30 seconds. There is a circadian variation of lung function, like there is a circadian variation of everything else in the body. In even healthy individuals, best pulmonary function will be at about 4 o'clock in the afternoon, and worst pulmonary function is going to be around 3 o'clock or 4 o'clock in the morning. In people with lung disease, in this example, or people with asthma, there is a worsening. If you take people with COPD, even people that have a PO2 that is actually pretty decent, certainly above the level to need oxygen when they're awake, when they fall asleep, the oxygen level goes down. In this situation, W is wake, Q is quiet sleep, that's non-REM sleep, and then the last part, A, is active sleep. So what we're seeing here is a continuous decline in sleep in COPD patients down to very low levels when you get into REM sleep. And the PCO2 likely also will rise out of proportion in COPD patients compared to normal individuals. So even if it's in the 40s when they begin, it's up in the 50s when they get to sleep. That's without doing anything else. That's just falling asleep. So what does this mean? Well, it's illustrated by this study which we did in my lab a few years ago. We took a number, actually 8 COPD patients that had moderate chronic obstructive lung disease, and but resting PO2s that were not needing oxygen, with saturation over 90%, and no history of cardiac disease, and no disease by echo or EKG. And we brought them into the nuclear medicine department, put them to sleep under a gamma counter, and we did first pass and mug-up radionuclide studies of their heart to estimate right and left ventricular ejection fractions. And we moved all of our equipment from the sleep lab into the nuclear medicine lab and hooked them up for sleep studies and waited for them to go to sleep. And then we repeated everything during the first REM episode that showed more than 4% oxygen desaturation. So we repeated everything when they were hypoxic during REM sleep. And by golly, they all did become hypoxic. And then, because we were obsessive compulsive, in the morning after they were no longer hypoxic, didn't move, but now were awake, we repeated everything again. And then we took these patients and we gave them oxygen, and we gave them enough oxygen to keep their oxygen saturation above 90%, brought them back into the nuclear medicine department, and repeated all these studies all over again. So that was the study protocol. What we found was that the left ventricular ejection fraction didn't change during hypoxic sleep or in the morning. But what happened was, even though for the most part, that one study in the middle of the night didn't show much of a drop, except for this one patient who seriously decompensated and had to be taken out of the study. What happened was, in the morning, most of the patients were very decidedly affected by this all-night hypoxemia and had a reduction in their right ventricular ejection fractions, but not their left ejection fraction. This is illustrated here. Patients at baseline with a RF around over 45%. During hypoxic sleep, no significant change, but in the morning when they were awake, no longer hypoxic, saturation 92%, the right ventricular ejection fraction was significantly depressed. Why was that? Well, it turns out that if you look at the hypoxic scores, the amount of time spent below 88%, the patients that decompensated and had a reduction in right ventricular ejection fraction had more time that they were hypoxic below 88%. It's illustrated here in these two graphs. Those with a decrease in RVEF, more than 2 hours with saturation below 88%, and those without a change, 20 minutes. Gave them oxygen, brought them back, and no longer was there any change in right ventricular ejection fraction. This is illustrated in these sides. Nocturnal hypoxemia, RVEF, base supplemental oxygen, no change in RVEF. That's the right side of the heart, right-sided pressures, pulmonary hypertension, and right ventricular disease. Now, this is somebody not with COPD. This is somebody with just plain obstructive sleep apnea with an arterial line in, and this is the systemic blood pressure corresponding to the hypoxemia and the arousals that are occurring during each episode of apnea. Why is that? Well, it turns out that in patients with obstructive sleep apnea, unlike those COPD patients with sustained hypoxemia during the night, there's intermittent hypoxemia. The obstructive events with the intermittent hypoxemia wind up with enhanced sympathetic tone and directly from the hypoxemia in the carotid bodies, and because of arousals that result from the recovery from the sleep, from the apneic events, resulting in enhanced mean arterial pressures, systemic arterial pressures, and this increase in sympathetic neural activity persists even during wakefulness. So obstructive sleep apnea, the nocturnal episodic sympathetic activity, is the most important factor in causing hypertension. It's quantitatively linked to diurnal blood pressure. Intermittent hypoxia and reorganization causes systemic hypertension, but sustained hypoxemia causes pulmonary hypertension, not systemic hypertension. There are intrathoracic pressure changes, inflammation, and then this is inflammation in obstructive sleep apnea secondary to the cyclic episodic hypoxia and reoxygenation mediated by NF-kappa B. So we can sort of synthesize the relationship of blood pressure and sleep disordered breathing in the following way. Intermittent apnea caused by airway occlusion results in acute nocturnal blood pressure rise and eventually sustained daytime hypertension. The recurrent arousals without airway occlusion do not result in hypertension. Sustained hypoxemia results in pulmonary hypertension, but not systemic hypertension. And only the asleep blood pressure is correlated with the risk of cardiovascular disease. These are the results of the HYGEIA study done by Ramon Hermida in Spain, and we talked about those the last time that I spoke to you folks. The relationship then of overlap syndrome and cardiovascular disease is a very strong one. There's a significantly higher risk of hypertension compared to just COPD alone or compared to obstructive sleep apnea alone. There is an increased risk of peripheral vascular disease compared to obstructive sleep apnea, and there is an increased risk of pulmonary hypertension, both compared to COPD and especially compared to sleep apnea alone, the odds ratio of 5.93. Here are the data to support that. This is looking at the overlap syndrome and systemic hypertension. So the systemic hypertension versus in the overlap syndrome versus just COPD alone, significantly greater with the odds ratio of 1.68. And the odds ratio of 2 for developing systemic hypertension versus obstructive sleep apnea alone, twice as likely. So we know obstructive sleep apnea causes systemic hypertension. Overlap syndrome is twice as likely to cause systemic hypertension. And worse, we're going to, as we can see, that is going to take its effect at night. Pulmonary hypertension is the big one. The development of pulmonary hypertension is almost 3 times greater in those with overlap syndrome compared to those with COPD alone. And it is almost 6 times greater in people with overlap syndrome compared to sleep apnea alone, because sleep apnea doesn't cause pulmonary hypertension by itself. So the cardiovascular consequences of overlap syndrome are sustained hypoxemia causes pulmonary hypertension and right ventricular dysfunction. That's what you get from COPD. Intermittent hypoxemia with arousals and increased sympathetic neural activity causes systemic hypertension and left ventricular dysfunction. That's what you get with obstructive sleep apnea. So overlap syndrome results in both of these. I would be happy to take any questions.
If we have any questions, please just send it to me and I will get Dr. Castrota to answer them for you. Also, those online, please write down in the chat. In the meantime, let me just prepare for the next talk.